All right, let's talk about a microbe with a real identity crisis, Streptomyces griseus. For decades, this thing was a hero, right? The source of streptomycin, which completely changed the game for tuberculosis. But now, in our labs, it's popping up as a rare but pretty significant opportunistic pathogen. So let's dig into how this one-time savior became a modern-day clinical challenge.
Just so you know, for this explainer, we pulled everything from a comprehensive report by Gemini Deep Search, and all the visuals are from Microbe Canvas. We know a lot of you are experts in the field, so if you want to geek out on the primary literature, the full source notebook is available for you to check out.
So, here's our roadmap. We're going to follow a path that I think will feel pretty familiar to all of you. We'll start with the bug's unique history, then get into the weeds of the lab bench challenges, ID and susceptibility, and finally connect it all to the bedside, where our data really makes a difference. Then we'll wrap it up with the key takeaways for your daily practice.
Okay, first up, let's unpack this really fascinating paradox. How in the world did a celebrated microbe from the soil become something we're actually concerned about in the clinic?
Just look at this timeline. 1943, streptomycin is isolated. It leads to a Nobel Prize in '52. And then, pretty much radio silence. For over 60 years, Streptomyces griseus was nothing but a hero. It wasn't until 2013. Think about that, 2013, that the script totally flipped with the first documented human Mycetoma case. And today, it's firmly on our radar as a pathogen that picks on the vulnerable.
And that's really the key here. It is a classic opportunist. What does that mean? It means it doesn't bother healthy people. It needs a chink in the armor, a weakness in the host's immune system to get a foothold. So, who exactly are we talking about?
The patient profile is really specific. We're talking about folks with blood cancers who are going through chemo, patients on long-term steroids, people with advanced HIV, and a huge one, patients with things like central lines. Those indwelling devices are basically a superhighway for an environmental bug like this to get inside the body.
Okay, let's head over to the bench now, because this is where the story starts to get really complicated. Identifying Streptomyces griseus is, well, it's a genuine puzzle. Here's why.
This quote from the literature just says it all, doesn't it? Turbulent taxonomy. I mean, that word, turbulent, has very real, very frustrating consequences for us in the clinical lab. The main problem is with our go-to ID methods.
So here's the heart of the problem. Our lab workhorse, 16S RNAi sequencing, it gets us in the right neighborhood, but it can't give us the specific street address. It tells you an isolate is in the Streptomyces griseus group, but that's as far as it can go. For a definitive species-level ID, which is absolutely critical for an outbreak investigation or for research, you're looking at sending it out to a reference lab for multi-locus sequence analysis, or even whole genome sequencing.
This means we have to rely heavily on our classic micro skills. Think of this as your cheat sheet. On the gram stain, you're looking for those delicate gram-positive branching filaments. Super important, it's non-acid fast, which helps you start ruling out nocardia. And then you have all the clues on the plate. It grows slow, sometimes taking 5 to 14 days. The colonies are tough, leathery, and stick to the agar like glue. And of course, there's that smell. That pungent, freshly dug earth smell of geosmin. Honestly, that smell is often your very first clue that you're dealing with a Streptomyces.
Right, so once you have a pretty good idea of what you're looking at, the next crucial step is antimicrobial susceptibility testing. And this is where things get even more tangled.
The challenge you face really depends on where your lab is in the world. If you're in the US and following CLSI, the M24 document gives you a path. You can use nocardia breakpoints as a kind of surrogate. But if you're in Europe and following EUCAST, you're in a tough spot. There is simply no clinical breakpoints for Streptomyces. You have to just report the raw MIC value with a cautionary note, which, as you know, leaves clinicians with a ton of uncertainty. It's a huge problem when you're trying to give clear, actionable advice.
And you absolutely positively cannot skip doing AST. Why? Because you can't just follow the old actinomycosis playbook. I mean, look at this data from the CDC on Streptomyces griseus isolates. We're seeing shockingly high resistance, 80% to ampicillin, 57% to Cipro. Trying to treat this empirically is a massive, massive gamble.
So what does actually work, at least in the lab? Well, the data we have points to a few more reliable choices. Amikacin and linezolid seem to have the most consistent activity. Then you've got this group of frequently active drugs like imipenem, minocycline, and TMP-SMX. But again, frequently is not always, which just hammers home the point. You've got to test every single clinically significant isolate.
So with all this complexity, how do we take all this lab data and actually turn it into effective patient care? And, just as important, a safe lab environment for us.
The basic idea for treatment is borrowed straight from how we treat actinomycosis. Because these infections can be chronic and create this dense, hard-to-penetrate tissue, the therapy has to be both high-dose and incredibly long. We're talking 6 to 12 months to really knock it out and prevent a relapse.
Internationally, this is the classic approach you'll see. Again, borrowed from actinomycosis. A really heavy-hitting IV phase with PenG, then a long oral step-down. But, and this is so important, look at that first-line agent. Now remember that 80% ampicillin resistance we just saw? This is exactly why AST is non-negotiable. This standard regimen could easily fail. That makes lab-guided alternatives, like doxycycline, absolutely essential. The same ideas apply for kids, too, just with very careful weight-based dosing.
And a quick note for our colleagues in the Netherlands, this is a really important point. If you look at the Dutch SWAB guidelines, there are no specific recommendations for treating Streptomyces infections. Period. This means clinicians there have to rely on the international literature and work really closely with the microlab to figure out what the MICs mean and come up with a treatment plan. Finally, let's talk safety. Streptomyces griseus is a BSL-2 organism, but it's got a special trick up its sleeve. Those mature colonies, they're dry, and they produce these little clouds of spores that can easily get aerosolized. The absolute key is to do all your work with mature plates inside a Class II biosafety cabinet. And when you open those plates, do it slowly, do it carefully. You really don't want to create a plume of infectious spores in your lab.
So, with all of this complexity, what's our role in all of this? What are the absolute most critical things we need to be doing in the lab?
Look, our job goes way beyond just reading a plate. When you isolate Streptomyces griseus, you have to become an investigator. First, look at the patient context. Is this just a contaminant, or is it a real pathogen in a vulnerable person? Second, be a precise communicator. Report the ID, but clarify that 16S only gets you to the group level. Next, be a patient advocate. Insist on getting AST done to navigate around that common resistance. And finally, be a partner to the clinical team. Proactively pick up the phone, explain the challenges, the lack of EUCAST breakpoints, the need for super long-term therapy. That conversation is absolutely key. And all of this leaves us with a really big question for the entire field. For these rare but serious bugs like Streptomyces griseus, how do we get beyond just borrowing guidelines from other infections? How can we systematically gather the data we need to build real, evidence-based clinical breakpoints and treatment guidelines specifically for them?
And that's our deep dive on Streptomyces griseus. If you found this useful, definitely subscribe for more explainers on the microbes that matter. We really value your expertise, so please share your own experiences and challenges with this organism down in the comments. We'd love to hear from you. Thanks for watching.